Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. On behalf of Saudi Epilepsy Society, I would like to welcome you all tonight and thank you for attending our special webinar on vagal nerve stimulation. It's my pleasure to welcome our guest speaker who accepted our invitation to present today, Professor Ahmed Abdel Muati. Professor Ahmed Abdel Muati is a professor of pediatric at University of Missouri in Kansas City and State. He's the director of Child Neurology Division at Children's Mercy Hospital in Kansas City and State, and also an associate chairman of Department of Pediatrics. He's the director of Comprehensive Epilepsy Center at Children's Mercy Hospital, and he's the director of Neurodiagnostic Program at Johnson's Country Community College Neurodiagnostic School. Professor Abdel Muati is an associate editor and reviewer of many peer-reviewed journals. He also had many publications in the field of pediatric neurology and epilepsy. Professor Abdel Muati tonight will present to us today a case-based practical approach to vagal nerve stimulation. So without any further ado, please join me in welcoming Professor Abdel Muati. Professor, please.
Well, thank you, Dr. Dana, for the kind presentation. It is my pleasure and my honor to be with you tonight, and it really is an honor to be among colleagues and professors, and as well as friends from the Middle East. So let me go ahead and share my screen. I hope you see my screen okay here.
Yes.
Okay. So I'd really like to kind of take us through a journey through how do we best take care of patients with drug-resistant epilepsy. It doesn't matter what country we're in, and it doesn't matter what clinic we're in. Epilepsy comes with a set of challenges and a set of problems that we all face. And it doesn't matter if you're adult neurology, if you're pediatric neurology, it doesn't matter if you're dealing more with neurogenetics or structural epilepsy. It's pretty much the same set of issues, and it's a very similar set of challenges that we face in the epilepsy clinic. So today we're going to go over some case reports. So the point is to address how can we deploy a protocol. So I'd really, through the next hour, I'd really like for us to think of a protocol, not just a case by case, because to be able to get to the best outcome and to be able to get to the best results, it's very important to know what's the next step I'm doing with my patient. So it's not a matter of which is a better choice. It's a matter of what's the next choice. And it's a matter of station. It's a matter of next step in treatment. So I'd like to start with a case that you'll find to be very, very common. I am sure each and every single one here on this call is following patients with similar presentation and has patients with similar presentation. The age might be a little bit different. The history might be a little bit different, but the end result is very, very similar. So that's an 18-year-old with Lennox-Gastaut syndrome. He was born at 26 weeks of gestation, again, prematurely. Sustained and suffered hypoxic ischemic encephalopathy, leading to static encephalopathy with spastic quadriparesis, hydrocephalus, and severe global developmental disability. So again, nothing unique, nothing unusual, something that we see a lot in the neurology clinic. Started having the very first seizure at the first day of life, and it presented again because of the hypoxic ischemic encephalopathy with epileptic spasms. Then went on to develop multiple seizure types, including focal tonic, myoclonic, atonic, and absent. So, which by definition, in addition to the developmental disorder, and I'll show you the EEG, is Lennox-Gastaut syndrome. He then started having the frequency of seizures started to really increase, and that's another important point that we all notice and we all know about our patients with epilepsy. So the family was reporting 10 to 20 seizures per day. But as I'll show you, when we admitted him to the epilepsy monitoring unit, we were capturing well over 50 seizures a day. A lot of the seizures are subclinical. Some seizures are very subtle, and the family and the patient cannot report. So that's something to keep in mind as we're treating patients with drug-resistant epilepsy. He was having about 1 to 2 status epilepticus per day, and from the list of medications, which you can see here, he's been on a lot of medication. Something that it's very unfortunate, and I have to give the disclaimer. this was not from my center. So this is before they came to us. He's been tried on vigabatrin, phenobarbital, carbamazepine, valproic acid, clobazam, lamotrigine, zonisamide, topiramate, and levetiracetam, which honestly, I consider it a bad choice to be on that many medications. I think somebody should have done something way sooner. When he came to us to the clinic, he was taking Epidiolex, which is the CBD, the FDA-approved form of CBD, as well as clobazam. So we'll talk about the timing and we'll talk about the choice of medications, but that's the story as it came to us. Here's an example of a seizure. So he's having those myoclonic twitches, followed by some tonic, then goes into a generalized tonic phase or a bilateral tonic phase to start easing up to tonic-clonic. So again, the very typical classical presentation that we all see. And as he's slowing down, he starts slowing down with the only clonic phase. So he went from myoclonic to tonic-clonic, then to clonic seizure. And again, even as he's slowing down, he does have some focal features of a seizure. So it's bilateral tonic-clonic as opposed to generalized tonic-clonic. So that's his EEG with the myoclonic twitches. So again, he has multiple abnormalities. So this is where with his myoclonic clusters. And again, he does have right here, he has an atonic, a brief atonic seizure with a high voltage frontal dominant generalized polyspike and slow wave, followed by a little bit of an attenuation of the background. And that's an example of his tonic seizure, as you can tell, with this electrodetrimental response, along with the superimposed muscle artifact, as well as the beta activity. As you saw from the previous EEG, he also has the slow spike, slow wave hallmark or signature that we typically see in patients with Lennox-Gastaut syndrome. That's his MRI, and the reason I have his MRI is to highlight that he is not a resection candidate, and I'll show you some examples that were resected or might be a resection candidate. He is not a resection candidate. He clearly has global atrophy. He has hydrocephalus that is shunted. He does have a significant hypoxic ischemic encephalopathy that's leading to the current picture. So he's not going to be a resection candidate. So when he came to us in 2015, we ended up implanting him with a vagus nerve stimulator. So remember, he was having multiple seizures, up to 50 seizures on a daily basis, was having a couple of status epilepticus, was having a horrible quality of life. So he was severely developmentally disabled. He was having severe behavioral and cognitive disabilities related to the epilepsy, as well as to the seizure medications he was taking as well. So that's what we did. So we implanted him with a vagus nerve stimulator. It was an Aspire SR. Then we gradually started adjusting his parameters, going all the way up to 1.5 milliamp, 2 milliamp, and 2.5 milliamp on the normal, out-of-stem, and the magnet mode, respectively. And with that, he had about 60% improvement in his seizure. So seizures now significantly got better. He is actually down to about once every 3 or 4 weeks. So even more than 60%, because if you count his myoclonic and his atonic seizures, he's probably more like 90% better seizure control. So significant improvement in his seizure control. The family reported, and that's another important thing, which I will come back to it as we talk about programming. The family reported that the magnet use stopped his seizures, and auto stimulation was very closely related to the magnet stimulation. So that tells us two things. It tells us that higher stimulation stopped the seizures and were needed to stop the seizures, number one. Number two, that his auto stimulation was accurate, because as the family was seeing the seizure, that's how we know the magnet worked, the device was seeing the seizure before even someone else sees the seizure and stimulate it with the magnet. So that's an important point, which helps significantly guiding the adjustment of the programming parameters. We were able to wean him off of the clobazam, so now he's only on Epidiolex, and much better quality of life. And again, he was taken completely off of the anxiolytic medications and has significant improvement in his sleep and was able to be taken off of his sleep aid medications. So someone might say, you know what, that's great. You know, we went down from 30 to 50 seizures a day down to 1 seizure every 3 to 4 weeks, right? But look at the parameters. So he's at 1.75, 2.0 and 2.25, which is not the most we can do with his device. He's only at 5 minutes off, which is 10% of his duty cycle. So the magnet works, and that's why I put it in red, because that's going to be a big deciding factor in how we program the vagus nerve stimulator. So with that, we started adjusting further. So he was having a good seizure control, but he was not having any side effects of the stimulation. He was doing better. So I wanted to make this even better. So that's what we ended up doing. So gradually, we started adjusting his current output to 2.5, 2.75, and 3 milliamps to the normal mode, auto stimulation, and the magnet mode, respectively. We also reduced his off time, or increased his duty cycle to 25%, and I reduced his frequency from 30 down to 20, and I'll explain why we do that. And we kept his threshold at 20%. As I go over the protocol, all our patients are the 20% detection threshold, because that's how you want to catch seizures as early as possible. So again, even though he was doing okay, he was doing good, he was doing better, some people might say he was doing excellent, with almost 90% seizure improvement, but he was still having some seizures, and I still had some room to adjust his vagus nerve stimulator, and that's what we did, gradually adjusting his current output all the way to 2.5 milliamp. Then we reduced his off time to increase his duty cycle to 25%. When we did that, he was having about once every 5 to 6 months, so significant improvement in seizures. He is only on Epidiolex, or the CBD, the FDA-approved form of the CBD, and was weaned off of all his seizure medications. Again, was taken completely off of all the psychotropic medications. And again, his CPAP parameters, so he has obstructive sleep apnea, and his CPAP parameters did not need to be changed with the vagus nerve stimulator. So remember, I put this in red and the 20 hertz to be able to go up higher on the current output. And I'm going to talk a little bit more about that as we talk about management of side effects. Reducing the frequency down to 20 hertz allowed me to go higher on the current output to make the patient tolerate the parameters without having any side effects, especially for those who have obstructive sleep apnea. They did not need any changes in their CPAP parameters. So what did I learn from this patient? I learned from this patient that as long as the patient continues to tolerate the device, and as long as they continue to improve, there really isn't a maximum current output. I have some patients who are completely maximized all the way up to 3.5 milliamps, as long as they continue to improve, and as long as they continue to tolerate the device. That's number one. Number two, we learned a lot from the magnet stimulation, that as long as the patient continues to improve and the family continues to report that seizures are better in duration, in severity, or in frequency as they stimulate with the magnet, that's a sign for me that higher current output will recruit more fibers in the vagus nerve, and that's what I need to get in the front end with my normal mode stimulation to continue to adjust and continue to improve. So again, the lesson I learned from this patient, the lesson we learned from this patient, is that as long as seizures are happening, even if it's 99.9% better, if it's still happening and I have room in the vagus nerve parameters, I'm going to adjust. I'm going to need to continue to adjust. What if side effects happen? Like I showed you, you can always address some of the other parameters, like the pulse width. And I'm going to go over that in a minute here. I keep all my pulse width patients at 250 microseconds. And I can always reduce my frequency from 30 to 25 down to 20 to allow for better tolerability. But the goal is to get the best outcome and the best efficacy by the device. And that's how we try to do it. Adjusting the current output, knowing a new baseline, then further adjustment of the current output, then adjustment of my duty cycle to get the best outcome based on the seizure type as well as the response to the magnet. So a little bit of a background. So why did this patient do that well? And if we were to go back in time, what would be done differently in this patient? And this is a very important question. I really want you all to think about, not just this patient. I'm sure as I'm going over this patient, a lot of you can see a lot of similarity between this patient and a lot of patients that you have in your clinic. So think about how many medications have you tried on this patient? think about what kind of discussion you had with this family. So this study by Schiller and Najjar goes over the success rate of number of medications. So like Brody and Kwan, even the medicines data from the VA back in the 1960s and the Kwai data in the late 2000s, the numbers are the same. So after the third medicine, my chance of making any change in seizures is very, very limited, 0.82%. So the idea of trying medicine number 4, 5, 6, 7 is very outdated. And it's actually something that I might do harm while trying to help my patient, because during that time, injuries can happen, side effects will happen, SUDEP, sudden unexpected death in epilepsy might happen. So trying more medications should not be an option. And we'll talk more about why, but it should not be an option. That's the punchline, or that's the statement that we all should take, that there should not be any trials of medications without an end at sight, without a goal at sight. So that's the number one step in our protocol. I should put a number of medications after which I need to move to a non-pharmacological therapy. It's even in the name. It's called drug resistant. Drug resistant. It is resistant to drugs. So me trying to improve something that is resistant with drugs using more drugs is an oxymoron. It really is not going to make it work because it's even in the definition. I promise I'm not going to go over every single thing on this slide. But the reason I bring this up is because it kind of has the majority of the medications we have available with its mechanism of action. So if you look, we have three main mechanisms of action. We have the sodium channel blockers. We have the GABAergic medication, can be direct GABA, indirect GABA, GABA transaminase inhibitor, it's a GABA. And we have the glutamic acid. So we have three main mechanisms of action. We have some special medications like the potassium channels, which are no longer really that much used. And we have the calcium channel blockers that again, like ethosuximide and some of the other potassium channel blockers that are very specialty, very specific treatment. But the main mechanism of action are three main mechanisms of action. Do you see the theme here? So we talked about three medications, three mechanisms of action. Think of any patient you have. After you fail the first medicine, you think of a different mechanism of action. After the second medicine, you think of a third mechanism of action. So by the third medicine, you've covered all those mechanisms on this slide. So any more medicine I'm going to be giving, I'm going to only be giving a different name, a different brand, but the same mechanism of action that I already knew that it doesn't work because the patient is continuing to have seizure. So what we see in that, I'm sure you all can answer that question. I only see some honeymoon period, some improvement for a little bit, then seizures start coming back. Okay, then the next step we all look at and say, you know what about epilepsy surgery? So just a little bit of a background. At my center, I do about 35 to 40 resections a year. I have about a little over 600 patients with ketogenic diet and almost 1,000 patients with vagus nerve stimulator. So the reason I bring those numbers is because absolutely, epilepsy surgery with resection should be and must be the answer if it is an answer. If it is an answer. We have a lot of patients, like the patient I showed you, epilepsy surgery is not an option. But what happens to those patients that we do epilepsy surgery for? So that's a study from the Cleveland Clinic, arguably one of the largest epilepsy surgery centers in the world, not just in the United States. And again, by great people. I'm sure a lot of you know those people. Almost all those people are very good friends of mine, and I know them very well. But the numbers are very similar. So roughly, I want to point your attention to the side here. So the chance of those people becoming seizure-free at 5 years was about 42%, and 33% at 10 years. What does that mean? It means that I have a third of the people continue to have seizures after the epilepsy surgery, and I need to take care of those people. So I again, do not mistake about that. Absolutely, someone who is a resection candidate, mesial temporal sclerosis, focal cortical dysplasia, some tuberous sclerosis, and even non-lesional epilepsy. If the patient is a candidate for epilepsy surgery, absolutely, I should not mess with VNS. I should not mess with ketogenic diet. It should be resection. But after resection, I have a large number of patients that will come back still having seizures, and I need to think about what's going to be my next step of treatment. So why is that important? Because of this slide here. And again, this is only some few examples with all the references at the bottom here of the injury, the healthcare utilizations, Think of the cost of to the family, to the system, to the insurance, to the government, with ER visits, with ICU visits, with laceration, with subdural hematoma, with hospitalization, with medication. So, and again, there's very good data and very good literature showing how I can flip that, how I can reduce that cost by early, and again, the key thing is early intervention with epilepsy. Think of the mortality and morbidity. Think of the anxiety. 70% of patients with epilepsy will have depression. 65% will have migraine headaches. Think of all the adverse events from the seizure medications. Think of the potential that gets lost: driving, getting married, having a social life, having higher education, being able to work, making family, and even the social stigma. So even in 2021, unfortunately, in the Middle East, in the United States, in Europe, I actually was just given a talk in Japan a couple of months ago. And in Japan, I got asked by a family as I was given the lecture, can my daughter transmit her epilepsy to her future husband? So in 2021, in Japan, they're still asking, can my daughter transmit her epilepsy to her husband? So we have a lot of wrong social stigma. We're still, unfortunately, afraid and ashamed to disclose that a family member has epilepsy. So those are all things that will limit the social activity, will create a lot of worry, will create a lot of depression and anxiety for the family members, for the spouse, for the parents. So those are all things that we need to address and we need to be aware of. So that really brings me to this slide here. So what is the goal? Because I cannot treat what I cannot diagnose. I cannot treat what I cannot diagnose. So my goal here is this. On the left side of the slide, the first, second, maybe third medication, my goal is to have 0 seizures and as less side effects as possible. But you and I know very well that a third of the patients, 1 out of 3 patients, no matter what I do, no matter what you do, it's not because I'm a bad doctor or you're a bad doctor. It's not because I have bad medications. It's because of the nature of epilepsy. A third of the patients, 1 out of 3, will have drug-resistant epilepsy. So I have one of two options. I can either say, nope, I'm not going to agree it's the drug-resistant epilepsy and call it the wrong name and continue to try to work it on this left side, which means I am risking the patient to all the things that I showed in the previous slide. Or I admit it is drug-resistant, and now I'm going to switch goals. And now my goal might not be seizure-free. My goal might not be seizure-free, but should not also be I'm throwing the towel. It should not be I'm not doing anything. It might be improving quality of life, maximizing the adherence, allowing for the least amount of seizures. And again, that's a very tricky thing. The least amount of seizures might be 50% in some patients, might be 80%, might be 100% in some others. I need to treat so I can see the results. I cannot say, no, it might not give me 100% reduction, so I'm not going to do it. No, that's absolutely the wrong approach. So that's my goal here. And I communicate that with the family. I let them know early on. My goal here, I've tried all that can be done with medications. At this point, medications are not going to get things any better. My goal is to try to get to the sweet spot and try to get to whatever the best we can do with the available data and with the available treatment. And in that case, it's a non-pharmacological therapy. So that's actually my protocol for my center that I put for my center. And again, we're a relatively large center. We're a level 4 epilepsy center. We're actually this year we're one of the top 3 pediatric epilepsy center in the United States, which means that we have a lot of referrals, and I have 40 providers. I have 24 physicians and 16 nurse practitioners. In the United States, a nurse practitioner pretty much functions almost like a physician. So to be able to ensure similar outcome out of those 40 people seeing epilepsy patients, I had to make sure that we're all seeing it similarly. And that's the power and the advantages of having a protocol. I cannot expect similar outcome if I continue to do something different with every patient. So once drug-resistant epilepsy is diagnosed, and again, it's a very straight, simple, forward, straight definition. 2 or more medications, despite which the patient is having any seizures in a 12-month period. Even 1 seizure, yes, even 1 seizure in 12 months period, that is drug-resistant epilepsy. And I need to put that patient in that track, in that treatment algorithm. Then the question is it focal or is it generalized? If it's focal, can be mesial temporal or non-mesial temporal. Mesial temporal, we typically do ablation for those. We do not do resections anymore. It's laser ablation. The patient leaves the same day. And actually in our center, 100% of those patients do not come back with epilepsy. We have a 100% success rate with our laser ablation for MTS. But some places, you know what? Resection or ablation might not succeed. And if it's a failure, I go with vagus nerve stimulator. What about the non-mesial neocortical? It can be lesional or non-lesional. For the lesional, I do invasive EEG and I confirm the location of the seizure, and I do resection. If it's a success, great. I don't want to see you again. If it fails, that's when I go back for vagus nerve stimulator. What about the neocortical that's non-lesional? I'm going to show you one of those cases here in a minute. It's a non-lesional neocortical extratemporal. Is it lateralizing? And if the answer is no, it is not lateralizing. I have it bihemispheric. It's a multiple semiologies. I don't have a lesion. Then you know what? I'm not going to do a fishing expedition. That's going to be a vagus nerve stimulator. If it is lateralizing, we typically now do stereotactic robotic guided EEG. So I do invasive EEG, and I do resection or no resection. So if it's a non-resectable, I just had one of those cases this week. We put the kid in the operating room. We put the stereotactic EEG, and then we recorded 3 seizures that were coming from multiple areas. Actually, one of which was coming straight right out of Broca's area. So we cannot resect this patient. So this kid actually is getting a vagus nerve stimulator this coming week. If it's resectable, I resect it. Same thing. If it succeeds, great. If it doesn't succeed, I go with vagus nerve stimulator. For the generalized, it's a lot easier. For the generalized, for most patients, it's going to be vagus nerve stimulator. For a small percent, might be a ketogenic diet. The very last resort. I will not put a corpus callosotomy in someone before doing a VNS, and I'll explain why that in a little bit here. So that's kind of how we do it at my center. That's how all my providers and all my physicians and all my nurse practitioners and even my neurosurgeons practice according exactly to the same protocol, which is very important. I need to make sure that I don't just have a protocol. I also need to make sure when I'm going to underscore when do I actually employ this, because it's not okay to wait 2 or 3 years to go to the next step in the treatment. So I'm going to go ahead and shift gears a little bit here and talk about vagus nerve stimulator. So why vagus nerve stimulator? What difference does it bring? So remember, I showed you the medication mechanism of action slide. Now I'm going to shift gears a little bit. So vagus nerve stimulator, it has very different thought to be mechanism of action. So like medications, we do not know the exact mechanism of action of medications. Vagus nerve stimulator, we do not know exactly what the mechanism of action, but there are a lot of studies for animal studies and even some human studies show me this. It increases my norepinephrine, which is an anti-inflammatory from the Lucas Ceruleus, and it's also an anti-epileptic. Okay, norepinephrine. None of the medications we talked about does that, number one. Number two, the thalamocortical blood flow, it actually improves the thalamocortical blood flow. So what does that do? It helps clean my microdendroglia, an inflammatory cell for the brain, and also helps the neurotropism of the brain. So I'm having healthier brain, blood flow. We didn't talk about that with medications. What about excitotoxicity? We know that the vagus nerve stimulator will desynchronize hypersynchrony, something that happens with every seizure type, generalized or focal. So now we're talking electrical desynchronization, which does not happen with any of the seizure medications that we talked about. It will increase my serotonin, and that's why patients with vagus nerve stimulator will have a significant improvement in quality of life, something we did not talk about with seizure medications. So the point is this: I have new and different and multiple mechanisms of action that I did not have and I do not share with seizure medications. And that's why, past the third medicine, I need something different, because what hasn't worked will not work. What hasn't worked will not work. So I need something different. And here's why vagus nerve stimulator is very different than any of them of the seizure medication that we've failed and that we've used. One other thing that, and I've taken a little bit step further, as I'm doing stimulation, when is the best time to stimulate? And that's where the auto stimulation comes to be of importance, and we'll talk about that. The sooner I stimulate, the better it is. So the earlier I stimulate, the shorter the seizure will become, and the more likely I'm going to be able to stop the seizure. So the earlier the stimulation, the shorter the seizure. Even in some cases, I can do it, I can stop it before I see ictal EEG. Absolutely, yes. So this is from the E36 and the E37 studies. Okay, so let's go to London. Let's go to Hamilton, another really good friend. We met right before the pandemic, right before COVID, and we compared data. Actually, even before she published this data, which I'll show you my data that we published in pediatric neurology, and this data I'm showing you here is an adult. Very, very similar. So if you're adult or pediatrics, the data is very similar. This is Hamilton's data. I'm going to show you my data here in a minute. So this is what happens with the Aspire SR. This is what happens with auto stimulation. So before, and this is from the Elites data, I wait 5 years to get 64% responders rate. With this, with the auto stimulation, Sentiva, and with the Aspire SR, I reached 60% at 13 months. So much, much earlier improvement. That's number one. Let's look at the breakdown. So I have almost 45 or 41% of the patients are at least 80% or better seizure control. So the overall, it's 60% responders rate, which means 60% of the patients had at least 50% or more improvement in seizures. But even as I break that down, I have a significant number that's 80% plus improved. So that's not to be belittled. That's a very, very important thing. Earlier stimulation, earlier improvement and more improvement in patients. This is a subset of patients, and we just published this actually in Seizure, the European Epilepsy Journal, that those who switched from one device to the auto stimulation device had a significant improvement in their seizures. So this is we published this, and this is Hamilton's data. I'm showing you what Hamilton showed, and shortly I'll show you our data that we published as well. That's the same thing. So I have more seizure-free patients. I have more of the 80 to 99%. And look at that. Even those who did not get the responders rate, now I have them in the responders rate. So those who were not getting the full benefit, now they're getting into that full benefit. So when we talk about seizures, it's not only the frequency, it's the duration, it's the severity, and the post-ictal period. And again, across all ages, this is in pediatrics, but also in adults, the same thing. It's 75% reduction in status epilepticus. I'm reducing hospitalization, and I'm also reducing the outpatient. I'm stopping 2/3 of children were taken off of benzodiazepines. At my center, as I'm going to show you here in a minute, 80% of my patients drop their medications, either one medicine, two medications, or completely. I have 10% of my patients seizure-free off of all seizure medications. One other thing before we go to the next case is it's not just the treatment choice, it's the timing of the treatment choice. And this is a very important thing. We talked about SUDEP, sudden unexpected death in epilepsy. We talked about the comorbidities of epilepsy, from headaches to depression to anxiety to suicide to sleep disorder to the cost to the social stigma, all of that. But also something we did not talk about, which is the longer I wait on epilepsy, the worse it gets. The kindling theory, the receptor tolerance theory, and the epi-enzyme formation theory. So those are three things I have to keep in mind. So next time I see my patient with drug-resistant epilepsy, as I talk to them, and we'll talk about how we talk to them, as I'm making the choice, if I do not make the choice to move forward with that non-pharmacological therapy sooner, that simply means, A, I can make the seizures worse, but B, I might not get the same outcome. So look at the left here. The purple curve shows patients who had their VNS implanted less than 10 years after the onset of the epilepsy. The blue bar in patients who had their VNS implanted more than 10 years after onset of epilepsy. So they both improved. They both improved. But the ones who had their VNS implanted less than 10 years from the onset of the epilepsy did better. So there's a time factor. There's an urgency. It's not like, okay, well, think about it and we'll talk about it again in 6 months. No, because in 6 months, the patient might not come back because of SUDEP. The patient might come back with worse seizures. And the improvement that I could have gotten 6 months ago, I might never be able to get now. That doesn't mean that patients who have had epilepsy for 12 years, 15 years should not get the device. And that's not what I'm saying. What I'm saying is 15 years better than 20, 20 better than 25, and 25 better than 30, and so on. So point is, the earlier, the better. Even though seizure freedom is not a goal of the vagus nerve stimulator, like we discussed, however, those who were implanted within the first 5 years of their epilepsy were 3 times more likely to become seizure-free. That study that was done by Renfro that showed that it's 3 times more likely to become seizure-free if I intervene early. So timing is a key here. It's very important to consider that. Last thing is SUDEP. the earlier I implant, the more likely I'm gonna get rid of the SUDEP, with 30% reduction in the SUDEP rates. Okay, so this is how we approach it. So kind of doing the Google Zoom approach, if you would. So first thing, I have to have confirmed epilepsy. I have to have documented failure of 2 or 3 seizure medications, not 5, not 6, not 7. It's okay if someone thinks, yeah, you know what, I don't like that. I might want to wait until 4. That's fine, but it should not be 5, 6, or 7. Etiology, any etiology, and I'm going to show you some more cases here in a minute, can be metabolic, can be genetic, can be unknown etiology, can be structural, like the case that I showed you. Any level of development. The one that I showed you was severe developmental disorder. I'm going to show you another one who's a perfectly normal, straight A student, doing great. So any level of development. Any age of onset. And I know in the Middle East, it is not age dependent. So in the United States, it's for 4 years and older. However, my youngest patient is 3 months old. So we do it in my center by weight. Once the patient reaches 7 kilograms and meets the above criteria, then they can be a VNS candidate. And the only reason 7 kilos is to be able for the surgeon to be able to implant the device. We avoid waiting time, so it should not be more than a year by any means. A year actually is a very long time. 6 months, the longest, which is enough time for me to adjust that second or third medicine. Remember, once the second medicine fails, it is drug resistant. I might adjust the second medicine, I might try a third medicine, but from that time until the patient is implanted in my center, actually it's around 6 months. It should not be a year, should not be 2 years, should not be 10 years, because again, the earlier, the better. And the patient cannot be a surgical candidate. So again, by neuroimaging, by EEG, by even sometimes by history, the multiple seizure types and the MRI showing multifocal abnormality. And again, of course, if the patient refuses surgery, or like that case that I told you about, the focus was sitting right over Broca's area, so I cannot resect that. So that makes the patient non-resection candidate. So if the patient meets those criteria, I move forward. So how do I identify those patients? And again, this is something that you all can say and see and experience better than I do. Frequent ER visits, the breakthrough seizures, those who have poor compliance, frequent status epilepticus, planned pregnancy. Think about that, please. Think about the planned pregnancy, that young lady who's having a seizure every 6 or 8 months, maybe not well controlled. As she's getting married and as she's planning pregnancy, I want to reduce medications. I want to make sure that she has a less risk of pregnancy problems. And that's when I will, if the patient is having 1 seizure a year and on 2 medications, I don't think twice about it. I will implant her to make it a safer pregnancy. It might allow me to reduce medications. It might allow me to wean some medication, and that's absolutely will help the pregnancy. And those who are experiencing side effects of medication. And those are some of the examples: my Lennox-Gastaut, my failed resection, my Dravet patients, my focal, my multifocal, the planned pregnancy, the traumatic brain injury, and those who I might not have an underlying etiology for. So it might be none of the above, yet they still have seizures. And I think this is something that needs to move forward. I am 100% sure, as I'm talking, a lot of you are thinking, oh, I have this patient, I have that patient. Go ahead and write that name down, because tomorrow or next week, you want to start moving forward with that planning. That's how we do it. So we do it in 3 phases. The first phase is going over the, everybody reaches that 1.75, 1.875, and 2 milliamp. Everybody is at 20% threshold. We typically do that within the first 8 or so weeks. Then the next phase, we do 2 to 3 months later. We look and see how they're responding. Then we make further adjustment, like this first patient, depending on the on-demand or the magnet stimulation. For the tonic-clonic seizures, we will increase to roughly around that range, and we'll drop the off time. For the myoclonic and absence, I'm going to show you a couple of cases of those. We typically go to the rapid stimulation. It's something that we reported in pediatric neurology about a year ago. We utilize higher DV cycle for those patients, and that's how we do the stimulation. How do I address side effects? First and foremost, it is very important to make sure that family and the patient understand the side effects. Reassure and explain expectations. Almost all of them, they get better and go away within a year. But if we need to, we can lower the pulse width. Again, I start all my VNS patients. Last year, we implanted at my center 97 patients with the pandemic and everything. And again, this is one of the advantages of the new model is the scheduled programming. 100% of those patients were started and continue to be on the 250. So if your patient is not already at 250 pulse width, that's a way to avoid some of the side effects. Reducing the frequency is the next thing. The last thing is to reduce the current output by 0.25 milliamp to allow for tolerance. Next is reduce the on-time, which is the very last thing. That's a last resort. For auto stimulation side effects, I want to make sure that my heart rate detection is proper so that the device is detecting accurately, reducing the stimulation on time. I have all my patients at 30 seconds because remember, you need an equal time of dormant stage in the device like your on time. So if you have the device set for 60 seconds, that means after it stimulates with auto stimulation for 60 seconds, it will be off where it cannot stimulate again for another 60 seconds. If you have it at 30 seconds, it's on for 30 seconds, and it will get back to stimulate after 30 seconds, which is half the time. So, but that's a way to reduce the side effects as well. Lowering the threshold sensitivity. Again, if it's 20%, you might make it 30% to allow for less stimulation. And last thing is reducing the output current by 0.25 milliamp. Okay, let's go ahead and talk about our next young lady here. So this is a 19-year-old young lady who has multiple seizure types and febrile seizures that started when she was very little. So she was born at full term, uncomplicated pregnancy. She has normal delivery. She started at 5 months of age. That was called, at the time, febrile seizures, but you'll see that it was not febrile seizure. And again, she started having the seizure frequency at the referral time was 10 to 20 reported seizures. She was having, by the family, 10 to 20, but when admitted to the epilepsy monitoring unit, she was actually having 30 to 40. And that's something that I please, I know that you all are aware of it, but please pay attention to her and be aware of it. When the family comes and tells me, this patient is having a seizure once every month or once every 3 months, I am thinking probably I'm multiplying that by a factor, by 2, by 1.5, by 3, depending on the seizure type. If it's myoclonic, if it's absence, or if it's atonic, I'm multiplying that by 3 or 4. If it's a tonic-clonic, probably it's about 1 to 1.5, because remember, there are some nocturnal seizures that might happen when no one is around. Point is that sometimes the family is not going to be accurate as far as reporting, and that's exactly what happened with this one. She had the focal tonic, myoclonic, and as well as atypical absence, with myoclonic being the most number of seizures. She's having 3 to 4 status epilepticus with severe developmental disability. She was actually living in a group home because of the behavioral outbursts she was having. So she could not live at home. Her family could not take care of her because of her behavior. And she was having a lot of behavioral outbursts and severe developmental disability. So I'm sure all of you know exactly what that is, right? Someone starts having febrile seizure at 5 months, then moves on to have a lot of myoclonic seizures, behavioral and developmental disability. That's a Dravet syndrome patient. That's an SCN1A patient. Before she came to us, she was started initially at oxcarbazepine, which of course made things a lot worse, the sodium channel blocker, then levetiracetam, valproic acid, and phenobarbital. When she came to us, she was in clobazam, brivaracetam, as well as Epidiolex. And again, her SCN1A test, when we did it, was positive. So she's a Dravet syndrome patient with mainly myoclonic, but other seizures as well. That's her MRI. She has some mild atrophy. She has a little bit of irregularity of her ventricles, but nothing resectable, nothing, of course, to go after. Her EEG shows you your typical multifocal slow spike, slow wave. In this case, mostly over the left frontal or left hemisphere. Also has some over the central parietal, occipital. She has the poorly sustained posterior dominant rhythm with moderate encephalopathy with theta frequency distribution. She also has this very famous beta activity that's seen in a lot of patients with Dravet syndrome, along with the following the slow spike, slow wave pattern. Again, more of her EEG showing a lot of the multifocal as well as the focal and the generalized encephalopathy. This is during one of her tonic seizures. So she had some myoclonic clusters right here, followed by tonic seizure. And as you can tell, the EEG kind of evolves, kind of has a little bit of an interruption, then has this tonic seizure. And here's another one that starts kind of focal, then quickly has a bilateral synchrony. So again, this was a focal with bilateral tonic-clonic on her EG. She has this right frontotemporal evolution of a beta frequency spike activity, followed by secondary bilateral synchrony with high voltage alpha frequency sharp wave activity. So again, she's not a resection candidate. She clearly has a lot of seizures. When we admitted her, we captured about double the amount of seizures as the family was reporting. She failed a number of medications. She has a genetic diagnosis with Dravet syndrome. And what we did here is we moved forward to vagus nerve stimulator. So what we did, we implanted her. That was her initial parameters, or actually the titration parameters, 2.5 milliamp with 3 minutes off. Her auto stimulation 2.75 and magnetism 3 milliamp. She stopped having generalized tonic-clonic with those parameters. She stopped having focal seizures with those parameters, but she had about 40% reduction in her myoclonic. So great, right? So she's no longer having the generalized tonic-clonic. She's no longer having the focal seizures. We were able to stop one of her seizure medications. The Epidiolex stayed only in clobazam, and stopped one of her psychotropic medications, but she's still having about 60% of her myoclonic seizures. We came back and actually adjusted her duty cycle. We reduced her off time down to 1.1 minute, and she pretty much almost became seizure-free. So I'm going to show you the follow-up here in a second. But because we did that, we also were able to reduce her current output, because with the duty cycle, she needed more duty cycle. And that is something that we noticed in the myoclonic and atonic seizure patients, that the higher duty cycle is needed in those patients. They need the frequent stimulation, not necessarily the longer stimulation. So this was 30 seconds on, 1.1 minute off, again, staggering her parameters, normal mode, auto stimulation, magnet mode. And with that, she had no more myoclonic clusters. So the clusters completely went away. She continued to have no generalized tonic-clonic and no focal seizures. She now has about 1 to 2 brief myoclonic seizures in a week, and we admitted her to the epilepsy monitoring unit, and that's per the epilepsy monitoring unit, so no clusters. She had significant improvement, and the key thing was doing that higher duty cycle for the myoclonic epilepsy. And so that's the point of this case, is that you need that for the higher for the myoclonic epilepsy patients. She was weaned off of all her psychotropic medications, and actually she moved home with her family. So imagine how this made a difference for the family and how it made a difference for the patient. She's no longer living in a group home because of the improvement in her seizures and because of the improvement in her quality of life and her behavior. She finally is able to go back home after 3 years of living in a group home. So, so again, not 100% seizure-free, but significantly better controlled seizure-free. But the more important thing is she's actually able to go back to live with her family. So what is acceptable? And this is again back to the protocol. What do we call acceptable here? We need to draw the line. It cannot be. It varies. The answer should not be depends on the patient. The answer should not be what the family wants. The answer should not be depending on the underlying etiology, because as you saw, and as we'll talk more, etiology doesn't matter. Level of development doesn't matter. The age doesn't matter, and the etiology doesn't matter. What matters is what I do and what you do. So I have to agree, and I have to put in my mind, and I have to put it on a protocol. How many medications failed? In my center, 2 to 3. It's okay if you decide 4, but it should not be 5, 6, or 7. That's number one. Number two, the frequency of seizures. I will put a very strong argument that any seizure in a 12-month period should be treated as drug-resistant epilepsy by the ILE definition. Some people might think on this call, well, but if the patient's having absence once every 3 months or every 4 months, think about this. Can that patient live independently? Can that patient drive? How do you feel about that patient's SUDEP rate, which we know it gets higher by the more seizures that happens? And why not make it better? I mean, just a simple question. Family expectations, something we'll talk about as well. Again, like we discussed, age type and etiology really should not make a difference. Those are some of the concerns that we all have. I haven't tried more medications. I think we addressed it. I should not try every medicine in the book. I'm done by the mechanism of action. Number one. Number two, the cost. I'm sorry, the family the patient might not become seizure-free. Yes, might not become seizure-free, but the point is I'm trying to improve things, even if he does not become seizure-free. The cost. Yes, the VNS costs money, but also it saves money. The data by Sandy Helmers that in about a year and a half, the VNS 100% recovers its cost and saves up to $60,000 per year. No hospitalization, no status epilepticus, no fracture, no ICU visits, and so on. I might scare the family when I bring it up. Bring it up early. Let them know that treatment map. Let them know before you start the first medicine that you might become seizure-free. If not, I'm going to add a second medicine. If not, we might talk about something like a vagus nerve stimulation. It's very important for them to understand that early on. And again, having that protocol, knowing the staff, connected with your neurosurgeon, and of course, being very familiar with the device. Those are some of the patient concerns. I'm not sick enough. My seizures only happen once every 3 months. I think we talked about that, and we talked about how that's not okay. I don't want to undergo surgery. 37% of patients with drug-resistant epilepsy will go to surgery because of subdural hematoma, fractures, dislocations, or lacerations. So when I don't want to send my patient to have a surgery, they might have a different, urgent, more serious surgery. That's something that's very important. We address the expense. It might not make me seizure-free. We discussed that. SUDAP, quality of life, all of that. Will I be able to reduce medications? Yes, 80% of my patients do reduce their medicine. And we talked about side effects, and yes, you can do MRI. Okay. This is a completely normal, developed young lady. I'm sorry, young man. So he is actually a competitive swimmer. He's actually trying. He's one of my patients. Very, very talented young man. He's a straight A student in school. He's also he's actually trying out for the upcoming Japan Olympics. So he's a very competitive swimmer. Great guy, very, very good at school, doing very well athletically. He started having seizures at the age of 8 with absence seizures happening 20 to 50 with about 1 to 2 generalized tonic-clonics per year. The duration is like any other absence, about a few seconds. He'd never had a status epilepticus. His MRI, as well as next generation sequencing genomics, were completely normal. Those are the medications he tried. He had some hepatitis and valproic acid. That's before he came to us. And those are the medications as he came to us. And ethosuximide actually was tried for a little bit here and stopped. Then again, I started him back on ethosuximide. With that, he had probably about 50%. So he's still having about 20 seizures a day. So he has what's very well known as drug-resistant absence epilepsy. We implanted him. And again, remember, as I mentioned, the quick seizures need higher stimulation. So he was at 2.5 milliamp. That's the higher duty cycle, 35% duty cycle. Myoclonic, atonic, absence, I go very quickly. So as I showed you, the protocol, I start and go to that first stage of 1.75. Then a couple of months later, I will adjust the duty cycle as I am adjusting my current output. And those are his parameters. He completely has no more generalized tonic-clonic. In a 96-hour epilepsy monitoring unit, he had only 3 absence seizures. The family was, 2 3-second absence seizures. So the family reported 0 seizures. When I admitted him, he had, by definition, as you know, 3 seconds is by definition a seizure and generalized 3 hertz spike and wave. So he had 2 of those in 5 days. So imagine coming from 20 seizures a day. And yes, he's not seizure-free. He's not seizure-free. But imagine the difference it made in his academics. So he's a straight A student. He's no longer needing any tutoring or any help with his school. He continues to function great. And again, I promise you, you will see him. If you like to watch Olympic swimming, you will see my patient going for the Tokyo Olympics this year. So he's doing great, and he's again doing significantly better with his vagus nerve stimulation. So again, academic performance even continued to get better. So real briefly, so in the next like 5 minutes or so, I want to go over the overall. So I showed you 3 cases. I'm going to end with one more quick case. But those are not unique. Those are not out of the world cases. This is from my data that we have all patients get to almost 75% reduction in seizures in 2 years. All seizure types, myotonic, clonic, atonic, myoclonic, and absence. And this is over 3 all the way up to 24 months. Significant improvement as you continue to go, with the caveat that those 3, I'm going to need to do the rapid cycling that I showed you. Significant improvement in quality of life, sleep, attention, academic performance, mood, all of them, they continue to get better. Side effects typically get better and go away within the first 12 months, but it's very important for me to reassure and to educate that this is something that gets better and goes away. As I mentioned in the very beginning, we have a very large ketogenic diet program, and some of you might have seen, we published in Epilepsy actually, and early this year in March, the patients were taking both ketogenic and vagus nerve stimulator. So your patient with ketogenic diet, if they're having any seizures, there's more work to be done, and they should get a vagus nerve stimulator, or they can get a vagus nerve stimulator. Also, every patient I have on ketogenic diet, the ketogenic diet can be for 2 up to 12 years. The patient that I have with the longest ketogenic diet is 13 years on the ketogenic diet. But eventually, 100% of the patients will have to come off the diet because the osteopenia, because of the kidney stones, because of the tolerance, because of the compliance, and so forth. But what do I do with those? I implant them with vagus nerve stimulation. That's something that you have to just consider. I'm going to show you some subsets of my patients. Those are my Lennox-Gastaut patients, again, across all seizure types, including spasms, significant improvement as time gets by, 3, 6, 12, and 24 months. Those are my Dravet patients. With 14 Dravet patients, 3 are completely seizure-free. Those are my Rett syndrome patients with a 60% reduction in their seizures. And again, remember, this is after all medications failed to get any better. So this is 60% from what they were doing on all the medications they were taking. Okay, what about, very quickly, corpus callosotomy? Corpus callosotomy is not the same. It has side effects. It's more invasive. It's not going to work for focal epilepsy. This is the Hari Shigani's work from Michigan. This is how it might improve things by 100, 75, 50, 25, 100%. And on the left here, you see that the number of corpus callosotomies in the United States significantly dropped as the vagus nerve stimulator came in the market in 1997. So something to keep in mind. And again, this is another study by Steve Krasowski from Cornell, another really good friend of mine, showing that VNS and corpus callosotomy, how it really may be additive. So I will do corpus callosotomy for those after I get the most out of my vagus nerve stimulator. So this is the no prior surgery, the 3 and 12 months improvement with a vagus nerve stimulator, and they are the ones with prior callosotomy. And as you can tell, it's even a little better if I intervene early before the callosotomy. So adding it after the callosotomy really didn't make a difference, but before the callosotomy, I might get better. So again, another reason to think of VNS before you think of corpus callosotomy. We talked about the diet, so I'm not going to waste your time with that. But again, I'm a proponent of the ketogenic diet. It has its limitations. The cost of the food actually is quite prohibitive, and it's not to be paid for by the insurance company. The side effects, the frequent visits, the labs, and the compliance, I don't like that about them. I want to present a very interesting case to you, and this is a Sentiva case. The previous ones were Aspire SR. This next one is a Sentiva case, the newest model. Just to kind of show some of the advantages this new device will bring. So this is a very interesting young lady, actually. One of the cutest girls I followed in my clinic. Very nice, super nice family, very, very smart young lady. When she came to me, she's 8 years old. She's right-hand dominant, perfectly normal, healthy, no medical problems. She started having nocturnal seizures at the age of 5. She was having 5 to 6 seizures every single night. And again, only happened nocturnally with right focal tonic with bilateral tonic-clonic seizures. So I did not get the consent from the family to show the video. I really wanted to show you the video, but I can't. But you can imagine, it's a right focal tonic with bilateral tonic-clonic seizures. She was having 1 to 2 status epilepticus per month, significant decline in her quality of life and her academic performance by our neuropsychology testing. Remember, she was perfectly normal before the seizure started. When she came, she was on lamotrigine, oxcarbazepine, and levetiracetam. She had negative genetics, including the autosomal dominant nocturnal frontal lobe epilepsy. I actually ran a whole genome sequencing on her, and it came back negative. We did an MRI. Her MRI was completely normal. She had a hypometabolism on her PET scan, and she did have hyperperfusion on her SPECT over that left frontal area. This is her EG, and she had this midline with left frontal lateralization buildup of alpha frequency shortwave activity that kind of dissipates into this this lower voltage beta activity with a superimposed muscle artifact. We did a stereotactic EEG on her, and we were able to locate where her seizures are coming from, and actually ended up doing an open grid and strips on her. So this is her EEG. And again, as you can tell here, for those of you who are doing electrocardiography and intraoperative monitoring, you can see where her seizures is coming from, very much right on top of that neocortex area that later was resected. So this is where her seizure onset is. Beautiful seizure. I mean, it cannot get any more localized than that. And the reason I'm showing you this, because we can do the best job possible. So this is clearly a non-lesional focal epilepsy. And I think we did a really good job identifying exactly where the seizure is coming from. Look at that. Again, for those of you who do epilepsy surgery, you can agree with me. This is a beautiful onset of a focal seizure. So the workup was good. The localization was great. The resection was a very nice resection. And after the resection, she stayed seizure-free for 1 week, and she gradually started having more and more and more seizures. And now she started having back to 5 to 6 seizures per night of the same semiology. A little less severe, and she didn't have any status epilepticus, and she did not have the severity of the seizure prior to the surgery, but she's still having 5 to 6 seizures per night. We implanted her with the Aspire SR back in 2016, and those are her parameters: 2.5, 2.75, and 3 milliamp at 25% daily cycle. She had 70% reduction in seizure. Great. Again, there was no more room. So her report came back with type 2B cortical dysplasia. So it became a fishing expedition. I did not want to go back to do more resection, because I figured every time we do resection, she has type 2B cortical dysplasia. She probably will have more seizures. So there's no point of going back and doing more resection. So like I was mentioning earlier, resection is the answer in those who are candidates, but some patients might not 100% become seizure-free, and I need to think of VNS in those patients. 70% reduction in seizures, no more status epilepticus, significant. So you know what? The family was very happy. I was happy. You know, she got much better. I was able to wean one of her medications, so now she's on only 2 medications, and she continued to do well in school. So she still will have a few seizures a week, but much better than she was before. Then in 2000, her generator went out, and we needed to replace it. So I replaced it with a Sentiva. That was last year, actually January of last year. So it's a little bit over a year now. So I was able to start it, and now I'm on the same daily cycle. I'm actually a little less during the day, but I was able to activate the day-night programming. Remember, this patient had all her seizures at night. So when I activated her day-night programming, I made it stronger at night, and even higher duty cycle, with a 35% duty cycle at 1.1 minutes off. But I don't need it to be that high during the day, so I lowered it during the day. And guess what? She's been 12 months completely seizure-free, not a single seizure. After she was implanted with the Sentiva, she's completely off of all her seizure medications. She just sent me a video a couple of months ago celebrating her 1 year seizure-free. It was a very cute video, thanking me and my team for making her seizure-free, or for her being seizure-free for that long. She's back to normal school. She was taking Prozac as an anxiolytic because of her anxiety with all the seizures. She stopped the Prozac, and she's really back to completely normal young lady off of seizure medications with this day-night programming parameters. So here's really the summary or the point of all what we've talked about. We need to identify drug-resistant epilepsy early. We need to make sure that we intervene early. It doesn't matter. I showed you cases with normal development. I showed you cases with structural abnormality. I showed you cases that failed resection, and I showed you cases with myoclonic and absent seizures. I showed you cases with severe developmental disability. I showed you a patient who had seizures at first day of life, and I showed you a patient who was 19 years old. So it doesn't matter, all of the above. So you have a lot of advantages, and we got to make sure that we intervene early. We got to make sure that we program according to the patient's tolerance and efficacy. There's no magic number. So I sometimes get asked, what's the highest you can program? The highest I can program is whatever stops or reduces the seizure, as long as the patient continues to tolerate it. So if I'm 99.9% better controlled, and I have room to adjust the device higher, I will adjust it higher. There's nothing to be lost. There's nothing to be to harm. There are some animal studies where they stimulated different cranial nerves, including the vagus nerve, not with the VNS, but with bipolar, all the way up to 12 milliamps without any damage from chronic stimulation. So I cannot damage the vagus nerve with only 3.5 milliamps, which is the highest I can do with a vagus nerve stimulator. The other thing is, as we do the titration, as I showed you, I don't titrate according to how the patient reacts initially. Everybody gets that 1.75 milliamp because that's the lowest I know that I'm recruiting and I'm stimulating enough fibers in the vagus nerve. Then after that, I take it step by step according to the patient and the family's response to that treatment. So I hope that was helpful. Again, it's an honor to be talking with you. It's an honor to be invited to this very esteemed society, and I'll be more than happy to take any questions.
Thank you, Professor Abdelmoati, for this wonderful talk. We enjoyed it a lot. And thank you for sharing your experience with us. We have some questions, if you allow me to read them for you.
Please, yes, please.
First, last slide was the comparison or advantages of Sentiva versus the Aspire. So there is a question about the new Sentiva VNS, if it is less sensitive for heart rate as compared to Aspire type due to the smaller size.
Absolutely not. That's a great question, but absolutely not. It's the same technology, so it uses the exact same parameters. So what it is, very briefly, so you have the generator itself and the lead that pretty much act like your antenna that's intercepting the cardiac heart rate vector. So it's the same technology, the same way, it is the same sensitivity. Even the 5 steps of the heart rate detection, it's the same as in the Aspire SAR. So there's no difference as far as the sensitivity between the Sentiva and the Aspire SAR.
Okay, thank you so much. There is a question if the VNS is contraindicated in patients with sinus tachycardia.
That's a great question. Absolutely not. So let me address this at a little bit about, I'll take a step back and address at a higher level. There is no, or the only indication, or the only contraindication of the vagus nerve stimulator is someone who does not have a left vagus nerve. That would be the only contraindication, someone who does not have a left vagus nerve. So someone who has sinus tachycardia, it is not a contraindication to have a vagus nerve stimulator. I might decide to adjust the auto stimulation parameters differently, or might even completely stop the auto stimulation because of the sinus tachycardia. But it is not a contraindication for someone with epilepsy. I can still get all the benefits of the normal mode and the magnet mode in this patient.
Okay, thank you so much. There is actually one practical question about the auto-stim. The question is, in the pre-op evaluation of the patient during EMU admission, if the patient didn't have any ectal EEG changes or ectal tachycardia, do you still going to switch on the auto-stim or just keep it off to reserve more battery?
Yeah, that's a great question. And so the short answer is yes. I never actually look to see ectal tachycardia in the pre-implantation EEG. The reason for that, if you think about it, someone who has 80 beats per minute baseline, and the increase by 20% during a seizure, so that's 96 beats per minute. Think about it on an EEG as I'm reading it with that one EKG channel. It's almost going to be impossible unless I bring a caliper and measure every single heart rate. It's going to be very hard to detect ectal tachycardia, number one. So the answer is no. You do not need to look for ectal tachycardia before implantation, number one. Number two, the battery life is not really a concern here. I did not put this slide because I wanted to put as much information, but I wanted to also be mindful of the time. I did not put this slide, but actually it's been done looking at the battery life. If I do 7 or more auto stimulation per hour, as opposed to 1 auto stimulation or less per hour. And the difference over a 5-year period is very, very minimal. It's only a couple of months. So my goal is not to save batteries. Let's be blunt here. I am not in the business of saving batteries. I am in the business of making my patients feel better. So if I implant a device and worry about the battery and not let the patient take all the benefit from the device to save 1 or 2 months, then no, I would not be on board with that. Even if I take the patient to the operating room 2 or 3 months earlier, but I give them all the benefits of the device, I think it's very well worth it.
Okay, thank you so much. There is a question about monitoring interictal EEG post VNS implantation. So is there any predictor in interictal EEG about the benefit of VNS or no?
Yeah, there are actually some case series and some reports about that. The short answer is no, there isn't. We actually sometimes will notice the beta activity during the stimulation. Sometimes actually we'll notice some normalization of the EEG. There's some data from Europe about the function, not the EEG, but about the function, the PET changes that happens after VNS implantation compared to prior. So you do have improvement in the metabolism. This is back to what we talked about with the mechanism of action. So you are improving the thalamocortical blood flow. You are improving the neurotransmitters. So with it, you are seeing some changes in the PET scan. But on the EEG, there really hasn't been any validated data showing that you do have EEG changes. But yes, you do see metabolic and yes, you do see vascularity changes after VNS implantation to the better, to the improvement.
Okay, thank you so much. There is one last question. I think you discussed this already in your slides about non-lesional focal. So the question about a male patient with up to 25 per day focal seizures lasting 8 to 10 seconds, would you consider VNS to improve his seizure frequency?
Most definitely, yes. And you know, some people might think, you know, okay, someone who's having 25 seizures a day, if I reduce it to 12 seizures a day, did I really make a difference?
Yeah.
So I'm going to go back and ask this. Does that patient have better chance to go through therapy? Yes. Does that patient have more awareness and alertness and wakefulness? Yes. Does that patient have less post-ictal period? Remember, the point is not only the seizure. Someone who's having 3 seizures a day, 3 seizures, that's a lot, right? So 3 seizures a day, each one lasting for a minute. So that's a lot, right? But someone might say, oh, so what? You know, he has 23 hours and 57 minutes that he's not having seizures. So the point is not the number of seizures. The point is not the duration of the seizure. The point is what impact those seizures will have on that patient. So 25 seizures a day, that patient is either seizing or post-ictally confused and post-ictally affected. So if I reduce that by 50%, I'm giving more life. I'm giving more quality of life in that patient's life. So the short answer is absolutely, I would implant this patient. And I showed you, I think, examples of that. My patient was having Dravet syndrome with 30 to 40 seizures a day, lasting 3 to 5 seconds. Absolutely, I would implant him. But let's take the other end of the spectrum. What if my patient's having a seizure every 6 months or every 8 months? Would I implant that patient? Absolutely, yes, for the same reason. You know, how long does it take as I'm crossing the street, not paying attention, for me to, God forbid, got hit by a car, right? So point is this, even if the seizure is very brief, I can fall, I can have a head laceration, I can have a subdural hematoma, I can get hit by a car if I'm not paying attention. So I would never, ever belittle any seizure, no matter how rare or how frequent it is, or no matter how long or how short it is. So absolutely, if this patient is in my clinic, he will be implanted tomorrow if they're not resection candidates.
Okay, thank you so much, Professor Abdelmati. So we'll conclude our session now. So on behalf of Saudi Epilepsy Society, I would like to thank Professor Ahmed Abdelmati for accepting the invitation to present with us today. Thank you, Worldwide Academy event organizer and trainers, for organizing this activity. And thank you, Livanova Company, for sponsoring this activity. Thank you to all our attendees who joined the webinar today. And on behalf of Saudi Epilepsy Society, I would like to thank you all. Have a good evening and goodbye.
Goodbye. Thank you so much.
Thank you so much.